Welcome to Same Surgeon, Different Light. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast. My name is Cherie Erkmen, and together with Sara Pereira, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We'll learn about backstories, career challenges, and what makes each cardiothoracic surgeon unique and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Today's episode of Same Surgeon, Different Light features two guests, the dynamic husband and wife team of Doctors Ross and Cherie Ungerleider. They're leaders in acknowledging that cardiothoracic surgeons are also members of families with responsibilities and needs that can at times conflict with the demands of work. Ross is a cardiothoracic surgeon who trained at Duke, where he remained on the faculty for 15 years, rising to the level of tenured professor and becoming nationally recognized for a leader in pediatric cardiac surgery. He has been a chair, a program director, and a recipient of the James Carreras International Humanitarian Award for performing heart surgery on children across the world. He is a certified coach with expertise in leadership development, conflict management, and relationships. He is a member of the AATS Wellbeing Committee and also spouse of our next guest, Dr. Cherie Ungerleider. She received her PhD in educational psychology from the University of Mississippi. She is a coach and consultant in teamwork, interpersonal communication, professionalism, and conflict management. She presented groundbreaking data at the plenary session of the AATS, shedding light on struggles that cardiothoracic surgeons experience while maintaining family relationships. She identified the most vulnerable populations as early career surgeons and those who had young children. She has multiple publications in this area, and it is a special honor to have the insights of both Dr. Ross and Cherie Ungerleider today. Welcome to Same Surgeon, Different Light. We are in our fourth season 5 podcast today and really honored to have Ross and Cherie Ungerleider with us. My name is Sara Pereira and I am a surgeon at University of Utah, happily joined by Cherie Erkmen. And Ross and Cherie, we are really delighted to have you on our podcast today. You have both led really extraordinary careers at top academic institutions and give leadership and wellness talks all around the country. Ross, you've recently come out of retirement to be a full-time operating surgeon again. And we really wanted to focus our talk today on all of your great work that you've done in wellness, as well as family and spousal support. To really help surgeons in our specialty learn from all of your research as well as personal advice from a successful marriage. I remember when I listened to your talk, Cherie, at AATS a couple years ago about spousal wellness in CT surgery, and I think the entire audience was overwhelmed that this wellness work-life balance talk made it to the big screen at one of our premier surgical societies. And you did a really amazing job. So can you tell us what really interested you in bringing wellness to our national organizations, and how did you do that so successfully?
We, as a part of the wellness committee, were very interested in surgeons. And so we had done a previous survey that focused on the well-being of surgeons. And then we thought, well, what about their significant others? and even their children, but so we started with the significant others because I think there are a lot of challenges in being in a committed relationship with a CT surgeon. And, there's a researcher out of Harvard, I think he's retired now, but a guy named Robert Keegan, and he talks a lot about competing commitments. And that really struck with me, because to be a CT surgeon, you have to be so committed to your career. And you also have to be committed to your significant other and your family. And sometimes those things get into competition, and it's just really hard. So,
And there are reframes that you
Yes.
use successfully with some people, because when we talk with people who are struggling through this, and by the way, we all do, it's sort of the normal part of being alive, is having competing commitments. But sometimes it's just a reframe that the energy and the dedication, and sometimes the attention, the attentiveness that I give my work, I'm doing in part to make my family secure. Because as long as I'm successful in my work, then my family can benefit from that success. And that's not just for me to be aggrandized. And so sometimes with that reframe, it's helpful for young people to understand, when they're spending so much time in the hospital and pursuing their career, that at least for their family to understand that there's a collateral benefit from that, and that if they aren't successful, they're letting down their family. And it does help
to
people.
reframe it. Yes.
Yeah. It's an interesting thing, Sarah, because I did my training in an era before there were work hour restrictions. This is the 1970s to the 1980s. I came on the faculty at Duke and started their pediatric heart program in 1986. So I trained in the decade prior to that. And we were on call every other night in the hospital, couldn't leave. And there was no duty hour restriction. So we typically got home about 10 o'clock or so on our nights off, which was every other night, and had to be back in early again the next morning. And we were perfectly balanced, and by today's emphasis on work-life balance, whatever, we stopped using that term years ago. We started talking about integration and choice. But I was making exactly the choice that I wanted. Early in my career, I wanted to learn as much as I could. I wanted to spend as much time as I could learning, developing skills. Certainly we worked about 140 out of every 168-hour work week, and none of us complained about it. And I don't think that we were burned out the way that surgeons today feel that they are. And there's a lot of cognitive overload and things that we can talk about that affect surgeons in today's world. We were physically and sometimes mentally exhausted, which is a component of burnout, but we didn't have that lack of a sense of personal accomplishment, another component of burnout, because we were really being allowed to have the ability to master some skills. And maybe some of us depersonalized. Jamie has some interesting research that she did when she was at Wake Forest, and had started for them a well-being program. And she followed a cohort of medical students through 4 years and found that of all the different parameters that define burnout, exhaustion, anxiety, I can't remember.
Yeah.
The only one that didn't have a phasic relationship to events in life, like taking step 1 or going onto the clinical services or whatever, the only one was depersonalization, that third element of burnout. There's emotional and physical exhaustion, there's lack of personal accomplishment, and there's depersonalization. What was interesting is depersonalization goes up slowly, but gradually it never comes back down. And I think by the time the students had graduated, and this was actually the class that our daughter-in-law, who's now a CT surgeon, is in. We don't know whether she was one of the depersonalized ones or not, but 50% of the students by the time they graduated were depersonalized. And once depersonalized, it doesn't go back down to normal. And so we're creating a culture that requires us to disassociate from our humanness. And if we treat ourselves like machines, expect ourselves to be perfect, and not have physical needs, we start treating other people that way too. And that's sort of what got me
Yeah.
interested in this along the way, because along the way, there's consequences to that. But I say that because the burnout that I think that young surgeons are experiencing today is a lot different than in an era where we really would have been burned out by all the criteria that people use today, like working way too long, being way
Yeah.
too tired, being beat up upon by surgical leaders who were not always kind in the way they language things.
Yeah.
But but today it's a lot different. And you're seeing people that are grappling with all these, not just the competing demands in their lives, but cognitive overload. There's so
Yeah.
many things going on.
How have you seen the culture changing from your early days of Duke to going back to North Carolina and now serving as an adjunct professor at Duke? It's fascinating to me who grew up in the every other day call of surgery and there were no 80-hour work weeks. Also, you have to have a whole new perspective on it now going back. And how do you see it differently?
Well, and there was a lot of collateral damage among
Sure.
your peers
Yeah.
in that training in terms of divorces.
And I think it was, back in an earlier era, it was considered a sign of weakness to think about relationships. I mean, you can explain, what happened to you before you gave your plenary talk?
Well, almost everybody on the wellness committee offered to go over the talk with me. And after a while, I thought, oh, they're worried. And then a few people said, no, Jamie, don't make it too touchy-feely. And so I'm like, oh, okay, I get it. And by the way, it was with really loving and sweet intent because they didn't want me to fail.
But it's a culture that we come from, that, Sarah, you had the same thing, and I certainly did back in I came on the faculty at Duke in '86, and touchy-feely was not allowed for surgeons. And touchy-feely takes a lot of courage to connect to your vulnerability. We gave, I think it was the same meeting where you gave the plenary talk, Jamie. We gave a 2-hour session on facing struggle, disappointment, failure and loss.
Yeah.
And we had some surgeons share some of their experiences, and we shared some of the work that's been done in terms of research around that. And it's something that we all struggle with from the day we start medical school, before that, really. And I can tell the young audience that you have that here I've been doing pediatric heart surgery for close to 40 years. And I still struggle when with how do I manage when I'm struggling with a patient, or there's loss, or I'm disappointed. How much of that was me? How could I have been better? So it normalizes it. You'll never get away from that. But just to be
Yeah, that's powerful, Dr. Ungerleider. Say that again. I think our audience would really appreciate it.
Well, I think the most important thing is to know that what you're having when you have those experiences is a normative feeling. We did a wellness session. I think it was the first wellness session that we did, where we handed out a list of about 25 or 30 experiences, such as when I lose a patient, I feel responsible, or something like that. And we had everybody in the audience check the things on the list that was true for them. I feel guilty when I take a day off, or whatever it might be. I still have the list. I just don't have it in front of me. And then what we did is we took all those pieces of paper, there were over 50 or 60 in the audience, and we shuffled them up and we handed them back to people.
Well, they were anonymous too.
Yes, well, they're anonymous, so the names weren't at the top. But everybody got a piece of paper that belonged to one of their colleagues. And as we read each question, we had people stand up. So they were basically standing up for one of their colleagues. I feel guilty when I lose a patient. Most people stand up, and they can look around the audience and say, wow, I'm standing up for one of these people, and somebody here is standing up for me, and we're sharing the same experience. So it's very important, I think, to normalize that and to remind people that the best way to get help is to ask for it.
Yeah. And I will share, when I was the director of the student wellness program at Wake Forest, a medical student would come in and they would share what was going on with them in their life. and we would talk about it. And then the next student would come in and they would share the same thing. And so after a while, I'd say, have you shared that with your friends? Have you told anybody? Oh, no, 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 I would never tell anyone. And it was interesting to me to be a witness to hearing person after person telling me the same story. And yet that fear, that fear of vulnerability and sharing it with a colleague. So I do think that's hugely important that everybody have a select group of friends that they feel safe sharing whatever's going on in their life.
Now, Ross and Jamie, I wanted to ask you, you did a really powerful survey looking at spouses or partners of cardiothoracic surgeons. Why did you do this survey, and what were you looking to find?
Well, I think it was very open-ended. We really just wanted to know what the experience of the partners of CT surgery was. And because we had the data that cardiac surgeons themselves had had some difficult times, we wanted to know, were their spouses or significant others having the same experience? And it was interesting to me because I kind of I guess as a researcher, you bias yourself if you expect, but I kind of expected the results we got. What did surprise me was after we presented the data at the plenary talk, how many CT surgeons came up to me and said, oh, I hope my partner wasn't listening to it. Oh, I didn't know. So they were genuinely surprised, I think, at the struggle and the difficulty that their significant other was having.
By the way, relationships are hard. And, think about all the teams out there that you work on that are full of people that you didn't necessarily choose to be in a relationship with, but you got a relationship with them when you signed on with your organization, as opposed to the relationships you have at home that you kind of relationships are hard because everybody has needs and everybody has differing perspectives and opinions and differing beliefs. And the beliefs that you have, which sometimes were created, just think about at work. You may be working with someone who has a totally different belief than you do about a way a patient's supposed to be managed or a wound supposed to be managed or the way you manage fluids or whatever it might be. And it's all been created by where they trained and who their family of origin, so to speak, was. And then they make a rule about, so when you see this, this is what you're supposed to do. And then those rules come into conflict. And that often is what creates a lot of divisiveness on all these teams, is that people have rules in competition with one another. And the same thing happens in families. They come together. And initially it's, we've done some work with a variety of different people like the Gottmans and others, but it's a wonderful term is you start out with positive sentiment override. You get into a relationship, it's a new job or it's a new relationship and it's like, wow, this is so great. This person is extraordinary, or this job is like the best job I could ever have hoped for. And then after a while, it begins to shift into negative sentiment override. You only begin to see the bad things. Everything's the same, but instead of choosing to see what was before was good, now you're seeing all the negatives. So she did it again. That's why she's so much of a jerk. That person I'm working with, he or she just keep doing this. How can they ever learn? And after a while, what happens is it begins to cascade into something that the Gottmans call comparison level for alternatives, or CL alt. And when people get into CL alt, they've basically checked out. I deserve better than this. This relationship is no longer satisfying to me, and I don't have the energy for it anymore. And I think that what's happening, and it worries me in the field of CT surgery, is that that's happening to people in their careers, early on in their careers, when they should be finding environments that keep them excited and supported. And it's the same thing that happens in relationships. By the way, all these skills are the same, whether they're relationship skills at home, learning how to dialogue in ways that aren't violent and decimating to another person, or they're the same skills that we use for some of the leadership skills. And the reason I mentioned it is that it's really going to be important for young surgeons today to embrace what we used to think of was touchy-feely. But the secret to being a great leader and understanding how to manage the demands of life is to learn more about how to manage yourself. You know, Peter Drucker said, if you can't manage yourself, you have no business managing others. And, you know, I say that because what Jamie heard after her talk was what some of the surgeons said. I heard we need to do more to be able to teach skills to people about relationships, which, by the way, would help a lot of people that go into leadership roles at work, but nothing ever really was done. We were asked to do just recently for the Southern Thoracic a course, 2-hour course on relationship skills. Then unfortunately I developed COVID the day we were supposed to leave, so I didn't go. But it's a shame, but I think that may be an opportunity for the STS or the AATS to really have some experts who've studied this begin to teach.
Well, and I just want to say
Yeah.
this. Ross and I have been married 24 years. We've been together 25. It was not a first marriage. We got married and 4 of our 5 children, all teenagers, moved in with us together, coming from North Carolina and Mississippi out to Oregon. And we got into therapy and it was very helpful. And so I completely, we sound like we've done a lot of training. We have a lot of expertise, but you know what? We've also been there ourselves and had to work through a lot of issues and have our own understanding.
Yeah, and it really is a good point to make, that you don't just know how to make relationships work because you've been in some good relationships. There's a lot of science out there, just like there's science in cardiothoracic surgery, and we've spent an
Well,
enormous
I
amount of
think
time studying it.
that's why your research resonates with people, is that you're giving this scientific approach to something that we may not feel we have any expertise in doing. So, can you give us a little bit of the science behind what you found in your survey that you think would be helpful to cardiothoracic surgeons?
I'm thinking about that. I think implicit in some of the feedback we got, because what we heard being a survey, it wasn't doing sort of a root cause analysis or anything like that. But the feedback was that significant others didn't feel like they had enough time for the relationship. They didn't feel like they had enough time for intimacy. One of the things that we all need from the people that are most important to us is to feel seen, heard, understood, and valued. We also want to feel like we're a source of delight for those who care about us. And that was very absent in the majority of experiences of the significant others of CT surgeons. And that to me is really concerning, because I also wonder what it's like for the children. Because if you've got an absent parent or a parent that's so preoccupied with their career, and it's an interesting thing, is more, and you know, y'all would probably know this more than me, but as more and more women have gone in to the field of CT surgery, the drive and the commitment to be a CT surgeon, a significant other, a parent, a partner, they're all important. You can't choose. And that creates, I think, that sort of moral injury that people talk about a lot, because it's all important. And nothing I mean, the stakes are so high in all 3, I guess is what I'm trying to say.
And I think what happens is that people get so busy, and today we have so many families that are 2 professionals trying to somehow manage their schedules. Not everyone, but a lot of people are in, dual professional relationships, and the data on that are really disturbing in terms of the outcome for those relationships. So what happens is people just get so busy with their own lives that they forget how to intersect the lives. And I can tell you, I mean, the more we learn, the more we think there are ways to help teach people to understand what's happening and to be aware. We had an experience just maybe in the last year. Well, I went into work on a Friday. Today's a Friday, expected to come home early. And there was a really sick kid that got admitted the night before. And although I really didn't want to do it on a Friday afternoon, this kid needed an emergency operation. He had acute endocarditis, a 2-year-old that had destroyed his aortic valve in essentially one day. And he was dying. His kidneys were shutting down. His liver was shutting down. He wasn't going to make it through the night. And so it was clear I had to take him to the operating room and do an emergency. I did an emergency Ross on him. I've done over 300 Ross operations. I can't think of very many that have been emergencies, but this one was. And I remember when I opened his chest and the aorta was just going flaccid with every diastolic, because there was no aortic valve. At any rate, I'm in there, we bring him back to the ICU, he's fine. I get back home by 8 o'clock or 9 o'clock at night. And Jamie wants to tell me about her day, and I'm still coming down from that adrenaline surge of just doing this. And we're able to look at each other, and I'm able to look at her and say, Jamie, I really do want to hear about your day. And right now, I'm just in a space where I just need some time to come back down.
Yeah.
And she got me some watermelon because she knows when I have a long case, that's always a great way to get fluids in me. But it's beginning to focus on thank you for that. You know, it's the thing that the Gottmans talk about, is trying to find the good. And so, you know, despite the fact that I was busy, she did something wonderful for me. I was able to say, this is not personal. I need some time, and then to be able to come back in 30 minutes and say, now tell me about your day. You know, so those are skills that people can learn instead of taking it personally, like, you know, well, he's just being a jerk and doesn't want to talk or whatever happens in some relationships.
Yeah.
I know that you've alluded to the Gottmans and given us so much great advice, but if you could pick one of the Gottmans books or the best advice that anybody's ever given you for marriage throughout your first marriages or currently, what would you tell us to read?
7 practices.
I think the 7 principles of making
Yeah.
marriage work, because it's a workbook you can go through. But some of their later books are, I mean, their concepts.
The book on fighting is really good too.
Fight Right.
Yeah.
There's a lot of stuff, and we actually studied with them when we lived out in Oregon, and then we started applying a lot of their things to hospital teams. A few things I would say that people can learn, and I think it might be in the article we wrote for Cherie. Accepting influence is huge. It's, you know, it is a important thing to not always just get your way, because we as surgeons, we know we're always right. And if people would just do what we tell them to do, everything's going to be okay. And if it's not, then it's because somebody else screwed up, right? I mean, I can't tell you how many surgeons I work with that just have so much difficulty letting go and letting somebody else have influence on their teams. And the same thing at home, to just every now and say, okay, well, let's try that. And then you sort of share the accountability of what happens. And so the easiest way to do that is for surgeons to do it when the stakes are low. You know, Jamie wants to go to a movie, I'm tired, but yeah, I can do that. We go out to dinner. You know, my colleague wants to do some different operation. Sure, that'll be fine. The things that the Gottmans say, probably that I think they would tell you from years and years of studying, and it's in one of their more recent books, was the love prescription. But they said basically of all the things that they've done over the years, there's 3 things. And one is to constantly explore, to learn more. We're still learning more about each other, but we think we know everything. And think about that on your work teams, you know, that I already know everything. So explore, because what we tell people, you're a verb, not a noun. And as soon as we label someone, then we stop their ability to grow. Okay, and none of us are who we were a year ago. So be curious. That's number 1. Be curious, explore, ask some big questions sometimes.
Yeah.
You know, not just, did you take the garbage out? That's a big question sometimes that needs to go out on a certain night. But, you know, what would be something you really dream about having in your life? Something like that. And but there's so many ways to, and we've made lists of questions. We were like that big question. So number 1 is constantly be curious. Who is this person? Remember when you first meet someone or you first join a team, you know how exciting it is to learn more about each person. And then when does that end? and it doesn't have to. The second thing is we've kind of said it before, but it's to find good things, because it's so easy to fall into negative sentiment override. To find little things during the day, you'll be rounding with someone and they just did say, you know what you just did, that's a wonderful thing that you do. And I want you to know I appreciate it. And the same thing at home, to try to remember to give constant little praise of things that really are meaningful and sincere.
Yeah.
But to try to focus on the good. We get so focused. Look at how our STS database works. What do we focus on? The 50% of patients that die. We don't focus on the 97% that we've actually helped. So how do we turn that around and start to just find little good things, that we can say? And then the third thing is to recognize and accept bids for connection. And, it's common to just make a statement. Somebody may say, you mind, can we talk about something? That's an obvious bid for connection. Yeah. Or maybe when, somebody at work might say, when you get a chance, would you mind grabbing a cup of coffee with me? That's a not so obvious bid for connection, but there's something that they want. Or it may just be a sigh or something, it's like you say something in the OR and, or maybe somebody in the OR says something, to you, and you just kind of go about your way, but they're making a bid that you might want to go back on. So to reconnect with people when they make bids for connection, find good things. Don't just focus on the bad. Be curious. Let people be verbs, not nouns. Yeah. Accept their influence. Those are probably as big as anything.
Well, and the other thing I would say is that if you live and breathe, you're going to have ruptures in your relationships. You're going to hurt somebody's feelings or disappoint them, or the same they with you. And I think it is hugely important to attempt to repair it. And, I'm sorry doesn't always mean like the act. I mean, I'm sorry that something I intended to go well didn't land the way I wanted it to. I'm sorry that you were disappointed, and people get so what we call super reasonable, trying to decide who's right and wrong. And I think if you put the relationship first, and I think that's hard for task-oriented people because they've learned to put task first. And so I think if you put the relationship first, then you want to repair it, you want to restore it. And that's really, I guess, Cherie, one of the things that came out of that the survey that we did is people really don't have the tools or the skills to go back and say, okay, you're the most important thing. Let's solve this together. Let's figure it out.
And, and that's interesting because embedded in that is genuine caring. Because to make a repair attempt with somebody that what Gottman's called the 4 horsemen of the apocalypse, but they're the things that we've recognized on teams that destroy teams. And it's criticism, putting the problem inside someone, as opposed to saying, we have a problem with this, let's all kick it around. Like a soccer ball, I'm not going to put it inside Sarah and kick you around. I wouldn't feel very good. But if it's a problem, we can all kick it around. So turning those criticisms into complaints. Contempt, which surgeons are really good at, thinking that they know more than others, and it's sort of that sneer of who are you, they even suggest. I mean, as opposed to appreciating differences, that we all have different perspectives, we all have different beliefs and different rules. So let me be curious and find out more about what you learned and when we should use that. Defensiveness, which we're really good at because the stakes are so high. So it's better to say, I didn't do that, as opposed to taking accountability. And sharing accountability on a team. And then the fourth one is that stonewalling. I'm too overwhelmed to talk about it, so I'm just pushing you off. And when people get physiologically overloaded like that, to be able to know that, but I need to come back. And so I'm going to take a half hour. I mean, there's prescriptions for all of this that we can teach people. But I say all those things because these are skills that can be learned, but they take practice. And you have to have compassion for yourself as a learner. I mean, just like when you learn to do CT surgery, you weren't able to do, whatever the double black diamond is in your field of procedures. I don't know what it is in thoracic. I can tell you there's some in congenital, like a Tausig Bing or something. They're big operations. But you couldn't do that right out of the box. You had to be patient with yourself. I say all those things because these are things that can be taught and learned and practiced. And I think that if the STS or the ATS or any of the organizations started having courses on this, we'd be creating surgeons that would feel more at ease with themselves and with the environment. They'd understand a little bit better the environments they're in. There's a famous golfer named Davis Love III, and his father was a golfer, and so he wrote a book about things he learned from his dad. I'm not going to give you a golf lesson right now, but one of the things his dad said to him was, Davis, never let your golf game determine your mood. Let your mood determine your golf game. And I started thinking, well, that's really true. We can do that as surgeons. And so before any case, because we get so busy, we go rushing into the room, I spend some time, and I'd recommend this to any surgeon. Sit in a quiet space or walk, do a walking meditation. I like sitting better if you can because your heart rate comes down. And just close your eyes and breathe and think about the case and what you're going to be doing. And go through the steps and imagine what you might do if you encounter a complication and how you'd respond to that, because chance favors the prepared mind. And then after that, just do some breathing and I always end by just giving myself a tender, loving kindness meditation with my hand over my heart, which I know is on this side. Not all of our patients are on this side. And just say, may I be happy, and may I be healthy, and may I be safe, and may I be at ease. It's within myself and in the world around me. I spend some time breathing out any disease I have, any anxiety I have about the case. And I breathe in my resourcefulness, and I breathe in all of my experience and my knowledge and my wisdom that I think I have. And I breathe out any more anxiety and any more dis-ease. And then I walk to the OR and I am totally centered. And I will tell you that if surgeons listening to this just try that one simple practice, if we tell them we want you to do some mindfulness meditation, oh, no, we don't do that, it's too touchy-feely. But if you do that, you're going to find yourself walking into the operating room, and there will be a noticeable difference that you'll have walking in centered, ready for doing the case, and your team will experience you that way. And you can do the same thing at home, with each other. So lots of little techniques to learn.
Ross, I totally agree with you, but I also feel like it's hard to convey that prioritization to trainees and our colleagues. So even when you look at the wellness seminars that we have at our national meetings, it's really hard to compete against the classic scientific sessions. So how do we make it a priority, or how do we convey this to a larger group of people? Because I think you are preaching to the choir, but then how do we get out, and how do we disseminate strategies of relationships, strategies of centeredness and well-being?
Well, it's that old saying, when the pupil is ready, the teacher will come. We probably need to have experts available to our societies that can, that have studied this, and people like Jamie, that just know how to work with people, but they won't come, you can have a session. We actually, because the meeting was going to be in Seattle this year, we were willing to contact John and Julie Gottman because they live there, although they're spending most of their time on Orcas Island now. But we couldn't get them a plenary session, and I wasn't going to ask them to come for a little breakout session. We did that with Dan Siegel at a meeting a couple of years ago, and we had a very small showing, and Dan's a friend, and so I don't think he cared much, but I felt bad.
Yeah.
But I think what you're asking, Cherie, is, how do we convey this to people? I think I don't know that you can. They have to want it, and they have to find some of the things that they get useful. Maybe stuff for families would be useful, because most people have marriages and families. And it was an interesting comment that the last person that stood up to ask a question after Jamie's plenary was a surgeon from France. And he basically said, maybe we should test and see if the spouses are right. Maybe what they're saying about not feeling comfortable with having enough time for intimacy and all that. Maybe they're wrong and they really do. And, you know, Jamie's answer, which I thought was perfect, but it's where a lot of surgeons are. Well, when we first got married, Jamie said Ross thought his job was to decide whether my feelings were logical or not. And you can imagine how well that worked out. And I mean, I
So
think
the
that,
same skills, it
yeah,
may be safer to develop some of those skills in a relationship
yeah,
at home and then take them to work
Yeah.
than to try to do them at work. And, you know, it's interesting. I thought about this so much because I do think the way that all physicians, but CT surgeons maybe in particular, are trained, sends a message that these skills are not important, you know, and really for survival, most CT surgeons have to, you know, put on the blinders, get highly focused on the path that they're on in order to complete the training. And I don't think, I mean, I think it would be cognitive overload
Yeah.
to try to develop these skills simultaneously. And yet, on the other hand, and I don't know if this is accurate, so, you know, I don't feel like I'm an expert here, but it seems to me that many of the skills for becoming a CT surgeon are very different than the skills you need once you become a teacher or a leader or a mentor, or you move into the roles you have after residency, where you know you're involved in managing and supporting people. And so now you've got both, but the intensity of the training is so huge prior to that.
And I think what sometimes gets misinterpreted, Cherie, is that we're trying to push that pendulum over so much towards wellness. And when you're a young surgeon coming out and all you want to do is prove to yourself and to the people you work with that, yeah, I can do this. And I'm not going to be, you know, I mean, this is what I've spent my life wanting to be, and here I am. And it's sort of like your cat carrier story, which Jamie can tell you in a minute. But we want surgeons to know they have permission to be totally absorbed in developing the skills that they've been training to develop, and going to meetings and learning how to do new procedures. Where they get stuck, you know, I give a whole talk now on creating a culture for innovation. If you need to learn it, it's because you don't know it. And so in order to learn something, you've got to struggle and you got to practice it, and you have to give yourself some compassion. But it's okay to spend time doing that and not see, well, I'm not paying attention to my well-being, because your well-being is in part associated with your sense of competence. You know, the ability to feel like I'm getting better at this and I'm gonna be okay. On the other hand, you're in relationships with people at home. They want you to be successful, but they also
And be there for them.
but they also want you to be there for them.
Yeah.
And so, you know, you have that
Yeah.
Billy, I guess it was.
Yeah. Well, real briefly, when I started my PhD in my 40s, I was all about just feeling all your feelings and just being authentically who you are, no matter what, in every moment. And one of the people on my dissertation committee, a very sweet man, took me aside for coffee one day and he said, you know, Jamie, I know they say all that in psychology, how we're just supposed to emote and be where we are. He said, but I just have to tell you a story. He said, I have a cat. It's my favorite cat. But when I'm trying to look at my research and go over, you know, my tables and all of that, and my cat is walking back and forth over all my papers, sometimes I have to put the cat in the cat carrier for just a little while so I can get my work done. He said, the important thing though, Jamie, is you have to always remember to go get your cat back out of the cat carrier after your work is done. And so it was his very sweet way of saying, it's okay to compartmentalize a little bit, Jamie, and do your work. And so that story has stayed with me and it served me very well. I did finish. Thank goodness I finished my PhD probably because of that.
So I don't think that you're going to find an answer to this until your question about how do we get people more interested, they're going to CT surgery meetings because they're trying to learn a CT surgery skill, or they're trying to network with other CT surgeons so they can learn, from them. It may be that our meetings are not really the best place. I mean, most of our meetings, people go without their families. Their families have to stay home. Maybe the kids have to, whatever it might be. Some of our meetings are a little more socially adaptable. The Western Thoracic is certainly that. It ends at noon every day. Families go. It's at a time when kids are in school. The Southern Thoracic is intended to be a family meeting, but it's a pretty full meeting, unfortunately. But it may be that what we should, the AATS, the STS sponsor seminars. They have the aortic symposium. We've done patient safety symposiums with Tor Sunt when he was president of the AATS. Maybe the AATS should sponsor a symposium on, relationships for CT surgeons and their significant others. And I would limit the, to make it really good, and let people come for about 2 or 3 days and learn these skills that can also help them become better leaders. And we put together a good faculty and some good curriculum, and people will learn. I know they will, because I did. Sort of, I'm still learning it. Jamie will tell you I'm still a novice at some of this, but yeah, but these are skills that people can learn and practice. And
we have covered so much great advice between our personal lives and our work lives, operating room culture. And, I had to just laugh for a minute, Ross, when you said that you were doing your pre-case, meditation and mental prep. And I do that also to kind of center myself before big cases. But I thought of you as an intern at Duke University doing your pre-case prep, and Halstead, or, one of the big
yeah,
giants walked in, and that just was not the culture. And so I think that what we see in the survey and what we see in our education programs is that our young, residents and fellows really need more guidance on how to succeed in their personal lives and in their marriage. And, we see divorce rates picking up during residency and fellowship and amongst all physicians. And so if you put yourself back as a resident or an intern, and had Cherie and I both as your program directors, what do you think the best guidance that we can give our young surgeons now in terms of how to really succeed the first 5 years of their career?
well, I can tell you this, and I'd love to know Jamie's thoughts, because she's a little closer to that. But when I was at Duke and Dave Sabison was the chair, and he asked each of us, I remember as a chief resident, and he said, "What can we do to make this program better?" It's sort of the question you're asking right now. And I gave him 2 recommendations, neither of which he took. In fact, my nickname was the ectopic beat. But there's another story about that. But the 2 recommendations were we should get a financial advisor for every resident to help them plot a course that can allow them to be financially secure. And we shouldn't wait till they become a faculty member, but because a lot of residents go into debt. I was going into debt. I mean, because we weren't paying them enough, and still don't pay them enough. I mean, frankly, if I give any advice to where, the CMS services or whoever pays for residents, let's give them a living wage. That would do a lot to get rid of some of the stresses and demands that they face. But I said, get them a financial advisor. That didn't fly. And the other thing I said, actually, I have 3 things I said. The other thing, get every resident today we'd call it a coach, but a therapist or somebody, a personal guidance person that they can check in with once a year, so that when they hit some of the bumps and the obstacles that life throws at us, they already have a relationship with someone they can go to, as opposed to saying, "God, my marriage is on the rocks. What do I do?" Well, I've been seeing, Jamie for the last 3 years because she's been sort of a resource for me. And maybe we could start by just going there and learning some skills that we can develop to keep things together. You know, the third thing I mentioned was we should have a gym in the hospital that we can go work out in, but that never happened either. But I'm just saying, I think that even that hasn't changed, because I think if we gave, you know, what we think of, let's give them more time, what we need to do is give them more money, and we need to give them more personal development resources.
And I guess my thought is, I think it has to happen at the systemic level. So I don't know if that's the ACGME. I don't know which organizations, but I think my favorite book is a little book called The Little Prince. And there's a wonderful line in it where he says, grown-ups love numbers. And so I think that we have to approach people with data and then ask them, how do we create systems? Because I used to say to the deans all the time, you can't put fish in a cesspool and expect the fish to not get sick. You can't have a system that values task and performance over relationships and expect people to have satisfying relationships. And so we have to find some way to integrate those things or to balance those things. So that's, I don't
Yeah.
have any
And-
ability to do that. but
And none
it's
of
my
that
thought.
in any way is contrary to how important it is to become a really good surgeon. I mean, I think about surgery and surgical technique all the time. I imagine that the reason I'm still being asked to do this at my age is because I keep wanting to learn. I do new things all the time. I'm not doing what I did 5 years ago. I continue to learn and grow, and I spend a lot of time thinking about it, reading about things, practicing things if I can. We just gave a national course here on, we've been over the last 10 years building RV to PA conduits out of Gore-Tex, which turned out to be really good conduits, much better than homographs and far cheaper. And we gave a course teaching people how to do that. But I don't want surgeons to think, well, if you just get to be a nice person and, pay attention to relationships, everything's going to be okay. No, you also have to be a really good surgeon. You have to be able to go into an operating room and do what the people need you to do. And so there has to be some time spent developing yourself in that skill set. And I always use the word and instead of but, because if you use but, it kind of says that other stuff's not important. But you'll become a better surgeon and a better leader of yourself, if not others, by learning some interpersonal communication skills. And there's so many things that people can be taught that are fun to learn and practice.
So I think I have to thank you for bringing science and the concept of peak performance as encompassing not only the technical skill, but also leadership and relationship skills. I think it's much easier to reach surgeons when you're talking about peak performance in many realms. So I really appreciate the work that you've done. I appreciate your sharing your personal experiences with you and your family. Given your experience, given your research, where do you think CT surgery is headed for the future?
Well, first of all, I'm really bad at predicting things, because every year I predict the Cubs are going to win the pennant, and doesn't happen. I want to say one other thing, though. If people are interested in some of our articles, and I do need to update our website, but our website is www.integratedlifeskills.com. And a lot of our publications are on there, except for the last few years, and we'll try to update that soon. Our book is on there. At least people can, people want our book, have them contact us. But as I know, it's still available on Amazon. But so I'd say if anybody is interested and wants to read, I'd recommend some of our work on whole brain leadership.
Yeah.
Our 7 practices of highly resonant teams is one that we're revising right now for our textbook. So that'll be updated. But there's some useful stuff there. Where CT surgery is going, I don't know, because I think it's going to go along the lines of healthcare in general. And I think that there are some real challenges ahead. I mean, we look at the satisfaction of people entering careers in healthcare, both in terms of earning capability. Now, across the board in healthcare, CT surgeons still fare fairly well compared to other physicians. And it's becoming a challenge. I don't think compensation's the be all and end all. I wish we started front loading some of that compensation during residency training so that people could be more, I mean, they get in so much debt. I don't know where we're going. I think technically we're getting better and better in doing all sorts of things. And I don't ever want us to lose that learning, innovative spirit. That part I don't worry about. I worry about who's going to want to go through the agony of training unless we change the way some of our programs are structured. Whether or not there's going to be the kinds of jobs that people are going to want. I don't have an answer for you, Cherie, but I think we're at a dangerous time where we need to not just keep modifying things, but really, you know, you guys probably have access to a lot of people that are, you know, think tank type people that I'd get people from industry and I get people from other areas that have had to work with restructuring how they do their business and find ways to be totally different about the way we train and then the way we work with our teams. I think that's our best resource going forward and not try to keep doing what we've done.
And expecting different results.
Yeah, right. But
Right. Well, I totally appreciate what you're saying, this diversity of thought and bringing in people from different perspectives and building these relationships and teams to meet the challenges for the future. And I thank you. I thank the STS for giving us the opportunity to speak to you. I think this is just invaluable information for all cardiothoracic surgeons to take home. Figuratively and literally. So thank you so much for your time and your expertise.
Thank you both.
thank you for
Thank you
asking.
so much.
Yeah, it's been a pleasure. We
And
really
people
appreciate it.
can feel free to reach out to us if they want to learn more.
And keep up the great work. We need you. So thank you so much.
Thank y'all.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.